Hello everybody, in this video I'm going to talk about the angiotensin converting enzyme inhibitors, which are the first type of the inhibitors of the renin-angiotensin system. Actually, as I said before in my previous videos of this series, heart failure stimulates some compensatory mechanisms within the body, physiological compensatory mechanisms, by the way. So as a try to overcome this problem and this issue, but unfortunately uh, these mechanisms will make the issue worse and worse, and will participate in the progression of this disorder. So heart failure, we know that it leads to activation of the renin-angiotensin system via two mechanisms. Okay, as I said before, first of all, by increased renin release by juxtaglomerular cells in renal afferent arterioles occurs in response to the diminished renal perfusion pressure produced by the failing heart. Sympathetic stimulation also will participate in the renin release by the juxtaglomerular cells. The production of angiotensin II, which is a potent vasoconstrictor, and the subsequent stimulation of aldosterone release that causes salt and water retention lead to the increases in both preload and afterload that are characteristic of the failing heart. In addition, high levels of angiotensin II and of aldosterone have direct detrimental effects on the cardiac muscle, favoring remodeling, fibrosis, and inflammatory changes. Actually, the inhibitors of the renin-angiotensin system uh, are two types or two categories. The first one is the angiotensin-converting enzyme inhibitors, and the second is the angiotensin II receptor blockers. The first type of the inhibitors of this system, as I said, the angiotensin-converting enzyme inhibitors or ACE inhibitors. These drugs or these agents are the agents of choice actually in heart failure. These drugs block the enzyme that cleaves angiotensin 1 to form the potent vasoconstrictor angiotensin 2. What is also important here to know that these agents also diminish the rate of bradykinin inactivation. Vasodilation occurs as a result of the combined effects of lower vasoconstriction caused by diminished levels of angiotensin II and the potent vasodilating effect of increased bradykinin. As we see here, by reducing circulating angiotensin II levels, ACE inhibitors also decrease the secretion of aldosterone, resulting in decreased sodium and water retention. So we observed the mechanism of action of these agents or these drugs in the previous slides. Now I'm going to talk about some points related to these drugs. First of all, I'm going to talk about the actions of these drugs on the heart. We should know that ACE inhibitors decrease vascular resistance, venous tone, and blood pressure, resulting in an increased cardiac output. ACE inhibitors also blunt the usual angiotensin II-mediated increase in epinephrine and aldosterone seen in heart failure. ACE inhibitors improve clinical signs and symptoms in patients also receiving thiazide or loop diuretics and/or digoxin. The use of ACE inhibitors in the treatment of heart failure has significantly decreased both morbidity and mortality. This figure illustrates the effects of angiotensin-converting enzyme inhibitors. As I said in my previous video, angiotensin II actually has many receptors around many organs and parts of the body. So when we will have decreased levels of this substance, which is the angiotensin II, So, due to the usage of ACE inhibitors, so the results will be as the following. We will have decreased output of sympathetic nervous system and increased vasodilation of vascular smooth muscle and increased levels of bradykinin and decreased retention of sodium and water. All of these things will participate in decreasing the preload and afterload, and of course will participate in alleviating and decreasing of unwanted symptoms and um, um, participating somehow in stopping to stop or prevention of the progression of this issue. As we see here, we have an example which is about the usage of enalapril and its effects on the cumulative mortality measured by percentage within time, which is measured by month, compared to placebo. Which means that in the placebo or the blue curve, here we don't have any agents, we don't have any drugs, and in comparison with the enalapril, where we used actually this drug. So here we see these things. First of all, enalapril, of course, decreases the cumulative mortality in patients with congestive heart failure in comparison to the placebo, as we see. The reduction in mortality is due primarily to a decrease in death caused by progressive heart failure. Treatment with enalapril also reduces arrhythmic death, myocardial infarction, and strokes. Similar data have been obtained with other ACE inhibitors. Now, the indications of angiotensin-converting enzyme inhibitors. Actually, ACE inhibitors may be considered for single-agent therapy in patients who present with mild dyspnea on exertion and don't show signs or symptoms of volume overloads. ACE inhibitors are useful in decreasing heart failure in asymptomatic patients with an ejection fraction of less than 35% or left ventricular dysfunction. Patients who have had a recent myocardial infarction also benefit from long-term ACE inhibitor therapy. Patients with the lowest ejection fraction show the greatest benefit. Early use of ACE inhibitors is indicated in patients with all stages of left ventricular failure with and without symptoms, and therapy should be initiated immediately after myocardial infarction. What about the pharmacokinetics of these drugs? Actually, all ACE inhibitors are adequately but incompletely absorbed following oral administration. The presence of food may decrease absorption, so they should be taken on an empty stomach. Except for captopril, ACE inhibitors are prodrugs that require activation by hydrolysis via hepatic enzymes. Renal elimination of the active moiety is important for most ACE inhibitors, an exception being fosinopril. Plasma half-lives of active compounds vary from 2 to 12 hours, although the inhibition of ACE may be much longer. The newer compounds such as ramipril and fosinopril require only once-a-day dosing. Now I'm moving to talk about adverse effects. These include postural hypotension, renal insufficiency, hyperkalemia, angioedema, and a persistent dry cough. The potential for symptomatic hypotension with ACE inhibitor therapy requires careful monitoring. ACE inhibitors shouldn't be used, of course, in pregnant women because they are phytotoxic. Thank you all for watching. Please like and subscribe for new videos.